have with us today. So I'm going to get started by introducing our SimCity Rounds presenter for today, April 20th, 2023. Thank you so much to all of you who've made the time to join us. We are grateful. And today we have Dr. Jabeen Fayyaz, who's a pediatric emergency medicine staff physician at the Hospital for Sick Children and an assistant professor with the University of Toronto. After graduation in Pakistan, she worked as a pediatric emergency medicine faculty at the Aga Khan University for 5 years. She is one of the few leaders in Pakistan that has an emergency medicine specialty recognized by the College of Physicians and Surgeons of Pakistan, and that was in 2011. She's also worked at the Sultan Qaboos University for 3 years, and she's led the implementation of the Canadian Triage and Acuity Scale, the CTAS, and also a quality improvement initiative utilizing Lean Sigma methodology. In 2016, she did a PEM fellowship at Sick Kids, followed by, and this is the part I love, a 1-year simulation fellowship. Since she has a master's degree in health professions education from the Aga Khan University and is currently enrolled in her PhD at the MGH IHP at Harvard. So she's the International Fellowship Program Director at Sick Kids and also the SIM Resuscitation Lead. She is the IPSS Inspire Fellowship Chair and the BOD member for Inspire and IPSS. For the past 3 years, she's been working with the national and international community outreach and capacity building in pediatric emergency medicine with partners at the Indus Hospital. And she has implemented a simulation-based PEM curriculum for emergency medicine residents and a 1-year PEM certification program with 27 physicians currently enrolled from all over Pakistan using distance simulation, which I'm sure she'll tell you about in this rounds. Her particular interest and passion is in exploring how vital culture play a role in facilitator and learner interactions in simulation-based education. Welcome, and I'm going to hand it over to you now.
Thank you so much, Phil, for a kind introduction. I'm very humbled. And just to reiterate, I did my thesis defense last week. So I'm just done with my PhD as well. So I would like to welcome everybody by saying hello, assalamu alaikum, bonjour, hola, namaste, marhaba, ciao, ni hao, ji ayanu, and sat sri akal. Thank you so much for providing me this opportunity to present my work in the area that I'm very passionate about. I would like to welcome the faculty members all over from diverse personal and professional identity in saying welcome in as many possible language, and I hope I have pronounced it correctly. I would be looking at my other screen for the chat, so please do not think I'm distracting or ignoring anyone. So today what I'm going to talk about is exploring the cultural sensitivity of physician and simulation educator. Initially, I decided to present all my 3 studies. Then I thought it is not fair. The work which I did in 2 years, how I'm going to explain it to everyone in just 40 minutes. So I just selected the second study, one of my study basically to present in detail today. So to give a little bit of more perspective, and at the end, I have my information. Anybody want to get in touch with me to know more about my work, they are more than welcome. With that, I will start. I do not have anything to disclose. And with that, there is a poll here, which I have encouraged you to participate because it is very important for us to know each other before we will dive into talking about culture. So you can scan this barcode and it will take you to a poll, or you can just go to the website, which is mentioned on the top part of the slide, that is pollev.com, and the name that you can put is jfayyaz653, or you can text jfayyaz653 to 22333. I will take a small pause here so that you will be able to set it all. Just give me some heads up if you are done by thumbs up, by any emoji that you want to. Perfect. So I started to see, yeah, how would you describe your setting in which you practice or teach? Like very diverse, somewhat diverse, not at all diverse. Very nice. More than half is saying very diverse. So I think I'm in the right place talking about the right thing. Great. It completely echo with the fact that we all in downtown Toronto or in Toronto GTA, we are dealing with all the diversified learners and interacting with the faculty members, which are very diverse. So the second part, which I want to put up front, is how important do you think is the awareness of cultural diversities in health profession education is? Great, completely agree. Then do you think cultural awareness should be included in the health profession educations? Yes, completely agree. And then this next, have you ever received any cultural competency training during your health profession education? Either undergraduate, postgraduate, residency, or fellowship?
The question didn't advance to this one. Oh yeah, here we
Oh,
go.
yeah, okay. Thank you, Tal, for mentioning that. Somewhat, yes. So this brings us to with the small scan of the environment that we all think that we are dealing with the diverse cultures in our setting, whether we are working, it is our patients, or whether we are as an educator and teaching with our interacting with our learners. It is very important to have a training, but we got it somewhat. So it is very important and high time to talk about these aspects. And then what are your thoughts about providing having a knowledge of cultural competency in providing a quality healthcare to your patients, which is our ultimate aim of us as educators or simulation educators. Agreed. So with this context, I just want to disclose few points about my own personal and professional identity. And Patel has explained a little bit about it, that as I was in Pakistan, I did my med school in Pakistan and then work as a staff physician for almost 5 years in Pakistan, and then interacted in that environment in different capacity with the learners, being the residency coordinator or program coordinator for the emergency medicine residency program. And then I moved to Sultan Qaboos University Hospital, where the culture is little bit different than what is the culture in Pakistan. And then I moved in 2016 to SickKids Hospital, which is kind of a new, like a completely different cultural interaction for me. And I would say some of the cultural shocks that I have been exposed to. And when I started my simulation fellowship, me as being from Pakistan and Oman, I have never been exposed to simulation in the way simulation is run here. Or I would say more broadly, the health profession education as it has been dealt in here. I still remember me being as a fellow participant in one of the simulation fellow mock court, and I actually do not know what to do, how much to say. And I was so nervous, and everybody thought that I literally do not know how to manage a critically ill child, although I have a like almost 10-year experience in working in a PEM. So that's why it is very, very important that as an educator or as a faculty in a academic institute that we should be aware of cultural perspective, and then simulation is accepted widely as a mechanism for improving patient safety, and integrating cultural aspect in simulation-based education is started to show. I know this is a new area in simulation-based education, but in last 2 years, if you pick up the literature, there's a tons of evidence that will show that if you integrate cultural perspective and pay attention to the cultural awareness through simulation, it will be a very rich medium to be utilized. So the overall goal of the project that I did as a part of my PhD study is to explore the cultural sensitivity among emergency medicine learner in simulation-based practices using distance simulation. It is the broader part, it is one of the study of the broader project. The first project was the implementation of a culturally adaptive curriculum. This is the second part to explore further the cultural sensitivity or awareness among the learners. And the third part is the validity evidence or LOSHI content validity of the tool that I utilize for this study. But I'm just focusing for today's presentation on this project. If you look at the world has become, I would say, a cultural village now. The geographical boundaries are non-existent. In any country or community, if you look at community of practice, I would say, and I would take the example of North America, almost 14 to 20% of the US and Canadian population are not born in Canada or US. And then there will be a moving trend when there's no one race, which will be a single majority if you talk about the geographical context. Cultural competency is known as an important and essential competency for medical practice, but if you look into the curricula, it is not widely adaptive in comparison to other aspects. If you look at the CanMed's role, it still does not have a cultural component, which is said very explicitly. And we know we all are educators and we have been involved in either curriculum development, implementation, or evaluation. And we all can echo to that how much this part is missing. Being aware of like this shifting demographic globally, our healthcare system must strive to provide the treatment and services which are culturally appropriate and effective. And I can give you tons of examples for my workplace where I work, that how different my interactions happen when I say the same thing to a person with certain beliefs or certain cultural background in comparison to other. Why it is significant? It is well demonstrated that to provide a safe and quality care, there's a need to train our learners to consider differences in ethnicity, in their religion, in gender, age, sexual orientation, socioeconomic status, language, education, ability, and geographical background. Believe me or not, culture has an influence on everything, from how people view their interaction with healthcare setting, or perceive you when you are interacting them in the setting. And it becomes very, very important when you are in acute care, because your time limit or how much you are interacting is very small. You do not have even a previous relationship with them. They are just seeing a new person, and then they are coming in a situation which is very critical almost most of the time. Regardless of the healthcare provider good intention, if there's a lack of cultural understanding, it will lead to decreased compliance and poor health outcome. Before I will go deep dive into my methodology and result, there are a few of the concepts which I want to reiterate or talk about here. And the first is the distance simulation. Distance simulation, if you want to ask me in simple word what it is just implementing a simulation or training at a physical distance from participant. For example, we all are here in a Zoom setting. We are all sitting at a distance and we are interacting and learning and having this conversation together. So if you add a component of simulation, then it will become a distance simulation. So it is this is like a simplest way you can understand it. And the distance simulation include anything, like it may include operating a simulator where some type of remote access where the operator remotely operate the simulator station, or the participants are located at a distant location. So if you look at the healthcare distance simulation dictionary, the Laurie Leosi has defined as a distance-based simulation as any interaction where the participant remote into something like cameras during a simulation where the simulator is stationed at a different site, which may be called as a distance-based high-fidelity human patient simulation training. The other concept, and I just was urged to include this while I was doing some of the literature search, and I really like this metaphor, which is presented by Julian Stott, who is a blogger. So I really like that he talked about our cultural alignment, which is an important next concept which I want to introduce. He talked about the primary alignment, secondary alignment, and some secret alignments. So our notion of culture seems like it's only tied to geography. For example, if I'm from Pakistan, I am Pakistani, or the religion I practice is Islam, so I am from the Islamic belief. He described that the culture is more than just your geography or where you born and what practices you just got from there, because there are secondary alignment to different communities and possibly we belong to or how we shape our culture. And some of the secondary alignment is our passion, like what we observe from being into different cultures and then what we adopt out of it. So that will become our secondary alignment to our culture. And then the third thing is the secret alignment, which is what is our intent. So cultures that are cohesive through intent. There are many things. While I was in Oman, I adapt from Arabic culture because I really like the way. And very simple example is there is a culture of using some scents, which is called bakur. And I really like that culture because we do have in our background or in our Islamic culture as well. But I really like that and I adopt from there. And then again, from their teaching and education, there are some of the things that I adopt in terms of their patient population, etc. And then some of my own passion, for example, which is my tertiary alignment or secret alignment, that how much I'm able to take the risk and how much cohesiveness I have with the culture, which is an example while I'm being in North America. In the beginning, I was so scared that am I able to be adjust in this culture? And then I really realized that there are some risks which I'm exposing to, but there's a lot of cohesiveness in this culture as well, which align very well with my beliefs and with my culture. So if you intend to define a culture, it is very difficult to define a culture. If you look into the literature, there's not a single definition you will find which will very explicitly say what culture is. But yes, there are some frameworks that has been described, and the one is by Leninger, which describe it as the learned, shared, and transmitted values, beliefs, norms, and life ways of a particular group of individual that guides thinking, decision, and action in a patterned way is called a culture. Or more recently, the Hofstede in 2011 have defined culture or expressed culture as being a collective programming of the mind that distinguishes the member of one group or category of people from other. So another important thing to understand culture is the iceberg model, which is presented very early on in 1976 by Edward Hall, but it is not in a lot of fashion, I would say. So what he described that like an iceberg, the 10% of the culture is on the external or the surface, which is easily visible, like how I dress, how I talk, what is my tone, how I carry myself, what is my etiquettes, and how I eat. So these are only the external perspective of my culture, which is visible when I interact with any other person or any other educator, etc. But 90% of the culture is internal or deep, and it is hidden. So in order to understand any group of people or any person, the portion which is under the surface need to be understood first in order to provide either a care or education to your learner that is meaningful for them. And those include the customs, morals, values, beliefs that we have, which is like developed over years, and it cannot be changed in days. It again take years to get changed. All these things get further complicated because when I was looking at or deciding what I'm going to study, the culture has many things in the literature. You will find cultural awareness, sensitivity, competence, and humility, and many, many other terminologies that you will come across in the literature. So how I have make the sense of it. So if you come to the cultural awareness involves the ability of standing back from ourselves and becoming aware of our cultural values, beliefs, and perception. That is why do we do certain things in a certain way? How do we see the world? And why do we react in a particular way? So this is the first step, and it's only just the awareness. If you go to this, I would say they can be interchangeable. It is not that they come after each other. There is multiple intersection in these four terminologies, but yes, I see a progression. As much as you mature, first you will develop awareness, then you go to the sensitivity, which is employing one's knowledge, consideration, understanding, respect, and then tailoring after realizing awareness of self and other, and encouraging a diverse group of individuals. Like being sensitive that yes, you have this awareness about yourself, your culture, but you are okay to understand, consider others' perspective as well, which will lead to the third component, which is competence, which is an ability to understand, appreciate, and interact with people from cultures or belief system different from one's own, and a positive attitude toward culture differences and a readiness to accept and respect those differences. And then it ultimately leads to the humility, which is a personal lifelong commitment to self-evaluation and self-critique, whereby the individual not only learn about another culture, but one start with the examination of his or her own belief and cultural identities as well. And what does all this paradigm help you to understand and appreciate your own culture? It minimizes the impact of your cultural myopia, I would say. It allows you to empathize with the people who you work with, and then it stops you to being made quick judgment calls on others' behavior, and ultimately it leads to to reduce the mistakes, errors, if you talk about the patient care, but also I would say the errors that you might make when you are dealing or teaching in a culturally diverse learners. It also improves your communication and collaboration between colleagues, which will foster the creativity and innovation within the workplace. So with this, I would say it is good to say at this moment, after going through a lot about culture, that the cultural lens is a good way of thinking about differences. We all, believe me or not, we all wear a pair of invisible glasses through which, when we see someone, when we observe anyone or interact with anyone, we shape how we see things around us. When we come from the same culture, same color, our lenses become more similar than the people who come when it comes from different countries, we see it differently. So the important point here is that we must stress that being culturally aware is not about compromising your own culture or sacrificing your own values or identity for others. It is simply about helping us understand that how we can best adapt our approaches, thoughts, and decision to ensure that we create a positive outcome in a cross-cultural interaction. So it's all about respecting other cultures as much as you respect your own culture. With this elaborative explanation of these two concepts, I would like to go to my objective, which was to establish an intercultural distance simulation experience between Yale PAM fellows and emergency medicine EM resident at Indus Hospital Health Network in Karachi, Pakistan, and to understand the cultural competence among the PAM fellows at Yale and EM residents in Pakistan through distance simulation. It was a mixed method study. The quantitative method was used by using a clinical cultural competency questionnaire and its analysis to assess the knowledge, skills, and attitude regarding cultural competence. And I'm going to talk a little bit further about CCCQ questionnaire in detail. And the qualitative method was the focus group and the qualitative content analysis after the curriculum completion. The phenomena of interest were baseline clinical cultural competency questionnaire scores of Yale PAM fellows and EM resident at Indus Hospital Health Network. And the qualitative portion, as I said, is to further deep dive and to understand the cultural sensitivity among Yale PAM fellows and EM resident while they are interacting through this distance simulation. The sim scenarios that we cover, and this might be appearing a little bit smaller on your screens, but I will explain it and it will be more explicit. That the sim scenarios that we covered were the normal core PAM topics, that is shock, airway emergency, status epilepticus, but we do add on some of the contextual topics like protein calorie malnutrition, which is more common in their context than our context. But we did adapt all these scenarios with Pakistani beliefs and customs. And some of the examples are delay in seeking care for a female child, lack of education, poverty, issues related to the healthcare access, vaccination hesitancy, and vaccine inequality. Also, some of the units that are used, measurement units used for lab investigations are different in there. For example, we use millimole and they use deciliter. Some of the local medication names, for example, we called acetaminophen, it's called Panadol in Pakistan, in contrast to Tylenol in North America. So we incorporated those aspects, and we were very lucky to have a medical anthropologist, one from Pakistan and one from Austria in our team. I developed the cases as a content expert, which is reviewed by the local content experts. And also we took the input from the medical anthropologist from Pakistan and from Austria for their lens to look at the scenarios, whether it is culturally representative or not. As I said, the participants are Yale PAM fellows. There were 8 Yale PAM fellows, and there were 22 Pakistani EM residents. Just to tell you, you must be aware that North America, Yale is no much different than SICKITS, but in Pakistan, which is this Indus Hospital Health Network, is in Sindh. And if you know, Karachi is one of the largest cosmopolitan city of Pakistan and 12th largest city of the world, capital of province Sindh. And it is very much diverse in terms of linguistic, ethnic, and religious backgrounds. You can see from the 2017 census, the number of the languages spoken only in Karachi, and with the largest number of the Urdu speakers in Pakistan, which are present in Karachi. If I talk about the Indus Hospital Health Network, Indus Hospital Health Network is one of the biggest philanthropic public sector hospital, which provide quality healthcare absolutely free of cost to millions of deserving patients through its countrywide network. Indus Hospital Health Network has a emergency medicine residency program for last 4 years now, and this is the 5th year. And there is a local faculty which has an interest in SIM, and the head of the department of Indus Hospital Health Network is my class fellow. So that's why I was able to collaborate and achieve what I'm able to achieve. If I look at the study design, we started with the baseline collecting data for the baseline clinical cultural competency questionnaire for the 22 EM resident and 8 PEM fellow. Then we run 8 distance simulation curriculum, which was 6 sessions among the PEM Yale fellow and EM resident, where PEM Yale fellows act as a facilitator and EM resident act as a learner. After completing this 6-week curriculum, we conducted 3 focus groups and did the content analysis of the focus group data that we received. Now, a few words about clinical cultural competency questionnaire. The Center for Healthy Families and Cultural Diversity, Department of Family Medicine at Robert Wood Johnson Medical School has developed this questionnaire, and it was developed in around 2001. Afterwards, it has shown validity evidence in various settings, for example, Greece, US, many other countries of the Europe. It has been very much widely used in the nursing literature and in the undergraduate literature. But the utilization of this tool in the postgraduate education is very limited. The questionnaire was used after taking permission, and there's a barcode here. If you want to look at the detailed version of the clinical cultural questionnaire, you can have a look. So I know this will be very small, but I just to give you a context that it is a very comprehensive tool, which includes some demographic characteristic, some information about the knowledge who is filling this survey, about the culture, their skills, their encounter situation, attitudes, and about the education and training they have received in the area of cultural competence. The distance simulation platform that we utilize is the virtual resuscitation room. And here is the barcode. If you want to go to the website of virtual resuscitation room and want to explore more, you can go through the barcode, or you can contact me as well. We use virtual resuscitation room because it is an interactive online free platform, which is built in by an emergency medicine good colleague, which is a good friend as well, Sarah Fuhe at the UHN. And then me and one of the faculty from McMaster, James Lewing, collaborated, and we developed PEM cases utilizing the virtual resuscitation room. And we implemented or revamped all our educational activities during COVID by this platform. So the virtual resuscitation room was chosen because it is easy to use, it provides collaboration and interactiveness, and it is very much responsive to the learner's action, and facilitator can, most of the time, they don't feel that they are doing in the virtual environment. So what happens in actual patient, when you are doing simulations in your either in situ environment or in sim center, a patient arrive, you work as a team, you debrief and learn. So the similar thing happen in the VRR. You will provide them a patient which is come in XYZ situation. They work as a team, and then you will debrief and learn. Only difference is that in actual sim lab or in situ, the VRR take over. So VRR does require only a Zoom connection, like we are having on a Zoom meeting, and it utilized the Google slide to complete the task and to run the scenario. And it was shared as a shared document among all learners, and all of the learners as a team can interact and work simultaneously in the Google slides. So this is an example of a virtual resuscitation bay in the Google slides. This is a virtual medication cart. And this is a virtual airway cart in the virtual resuscitation room. And this is how a glimpse where everyone is sitting in their own location and they are all interacting together through Zoom and through the Google Slide platform. This is some of the pictures of our sim session in action in Pakistan. And then coming to the most exciting part, that are the results. So I will talk about the quantitative result. So this is the demographic portion of the clinical cultural competency questionnaire. And I would like to say it is shown side by side, but we are not comparing from the Pakistani learners from US learners, because I won't say it is justifiable to compare two different culturally distinct learners from each other. So I would say define their demographic separately, and there's no comparison intent here. 78% of the Pakistani learners were female, and just to let everybody know that 18 of the total out of 22 learners were able to complete the whole module and participate in the focus group. And in US PAM, all 7 will be able to participate. So 78% of Pakistani learners were female, while 100% of the US learners were female. If you look at the ethnicity, quite diverse in terms of Pakistani learners, like Sindhi, Punjabi, like 50% were from like Urdu speaking. And in US, you can see like they are also of mixed ethnicity. 17% of the learners in Pakistan have visited or lived in any countries outside, while 100% of the US PAM fellows said that they have either lived or have visited countries outside US. When we talked about their like linguistic diversity and asked them, do they speak any language other than Urdu? In terms of Pakistani learner, 94% speak other languages other than Urdu, which is the first language spoken in Pakistan, while 100% of the US PAM fellows speak languages other than English. This is a summary table for the clinical cultural competency questionnaire with mean scores and standard deviation. And you see in in Pakistani EM resident, in knowledge, skill, encounter, and attitude, you will see the scores from anywhere from 2.87 to 3.47. It is asked on a Likert scale, which is from 1 till 5. 1 is not at all, and 5 is very much. So this is kind of a Likert scale. So they are falling in middle in knowledge, but skills, encounter, situation, and attitude, they are kind of towards the higher end. The same is true for the US PAM fellows. When we ask them, important thing here is to notice is that when we ask them, did they get any training about cultural diversity during their colleges and med school, there was very low scores, while it get better in the residency and fellowship. So it's kind of a thoughtful moment that how much education about culture we are providing to our learners in the undergraduate years. Coming to the qualitative analysis, which is the focus group, we did 3 focus groups. 1 focus group with the PAM fellows in US, PAM fellows from US, and 2 with the Indus EM resident. The thematic analysis, the main categories that come up were 3, that is learning experiences, the intercultural encounters, and the challenges. In the learning experiences, both EM resident and PAM fellows overall agreed that distance simulation training provide them with a meaningful interaction, although they were all that did not know each other, they were from different settings. And then they agreed that the interactivity during the simulation and debriefing act as a key component for the success of the training. So the EM resident mentioned that I have become more aware regarding counseling and understanding attendance worries regarding patient. And the PAM Yale fellows said, several of them mentioned that they also wanted to learn from colleagues in Pakistan about their work dynamic and work environment, and they are able to achieve that learning by having this interaction. Some of them, like in terms of PAM fellows, had no or few experiences as simulation trainers until this specific program. So in the beginning, they felt nervous and uncertain about their knowledge and skills because they were asked to act as a facilitator, and everybody has not have a lot of experience in facilitation. In the second main category, which is intercultural encounters, the 4 things which come up are ethnic and cultural diversity, linguistic diversity, cultural aspects surfaced in training, and power distance. In the intercultural encounters, we found ethnic diversity among all of them. Like they were all pretty diverse. All of the learners talk about diversity of language and cultural skills as being an important learning through this module. And most of the learners verbalize that the intercultural encounters help them to treat or dealt with the patients in a better way moving forward. For example, here, the several EM residents from Pakistan mentioned their needs for to fulfill praying duties during the simulation session. Some stepped away, others did not, but would like to do so. So it gives us as a facilitator, it was kind of an aha moment for us, because I am from Pakistan, and we were doing these sessions in the evening time, and there's two major prayers that comes up, and I put breaks, but I did not align them with their praying times. So later on, moving forward, I aligned them with the praying times. While PEM Yale Fellows said that this needs was perceived as interesting by the PEM Yale Fellows, but not further discussed because it was not felt important. And we all know from the North American culture, even when I'm here, I did not, if it is even a pray time or any other important task time, I just continue to do whatever I'm doing. And then later on, I do whenever the time is available. Several PEM fellows stated that they did not perceive any cultural related differences in the training in terms of a medical training in comparison to such a setting in US. So they said that the language of medicine is the same. And I think that helped them to bond very quickly, although their cultural or linguistic beliefs are quite different. One thing that comes up is the power distance. And the power distance, as Elmer et al., is a term that describes how people belonging to a specific group and how perceived power distance impacted communication between a culturally diverse learners or facilitators. So this is another thing that comes up in the data. The data highlighted that the US has been seen as a standard of how to practice pediatric emergency medicine, both by the Yale PEM fellows and the Indus EM resident. Pakistani medical reality was seen as the stranger, the alien, and the US as the medical standard. The expectation seems like that Yale PEM fellows have to learn about the Pakistani culture, and the EM residents have to learn about PEM from the Yale PEM fellows, although the Yale PEM fellows are in the training as well. So both sides appear to be quite surprised that both aspects of learning was bidirectional, that they are learning from each other, both in the medical aspects as well as in the cultural aspect. In both focus group, which we conducted with the EM resident, the topic of feeling inferior, having less knowledge about things keep on coming again and again, just because of the fact that they are from a low resource country and they were shy in the beginning to speak up because they thought they might be saying it wrong. And then they later on felt that this feeling go away because then they realized that the medicine is being practiced the same way. So then it become more colleague to colleague interaction moving forward. And that's how they felt that medicine is a common language that connects them. The last thing is the challenges. In the challenges, the journal challenge we have is the time difference of 9 hours, which make it very challenging for the Indus EM resident as training took place during morning of the EST. The distance simulation program is a new program to EM resident, and they were quite motivated and encouraged. Lack of some of the time access to internet, access to a good devices, not everyone has a personal laptop or desktop, was perceived as a barrier some of the time. The PEM Yale fellow recognized that they are not involved as a facilitator. So facilitating this, especially with a different culture, for the first time, they felt a little bit awkward, but then when they continue to do it, it will continue to happen very smoothly. So they encourage having a meet and greet and a orientation session in the start of such modules. They also said the use of chat window during the Zoom facilitation will help them to ask for help or clarify any of their queries, because the learner from the Pakistan keep on saying some terminologies. For example, ceftriaxone is called rocephin, and they do not understand what rocephin is. And they always used to ask, what is rocephin? Is it ceftriaxone? Because it felt like that. So they said that was very helpful. And then other three important things were highlighted about scenario facilitation facilitation and debriefing, which are kind of specific about scenarios, the participants felt that all the scenarios were very close to the local reality, and it generated some comfort for the Indus EM resident. And there are some surprises for them as well, that there are some of the aspects that they were not fully aware that they have to be learning about it. And then the Yale PAM fellow suggested to have local names of medication, as I was alluding earlier, to be part of the scenario writing, so that they will be aware that when they are saying a particular name of the medication. Several Yale PAM fellow in terms of facilitation mentioned that they are being as trainer themselves and asked to facilitate, which was a new experience. They do feel in the beginning unsafe, but then later find it a valuable learning experience. And also, they also said that sometime EM resident asked them a higher level question that they could not answer, although it were relevant, and they appreciate the co-facilitators present to help them out in there. In both the focus group, the Indus EM resident agreed that the Yale PAM fellows were empowering, and their way to give feedback was very positive, focused on good aspect first, and then showing the ways to improve, avoid negative framing. And the debriefing, all participants had the feeling that the debriefing sessions could run a little bit longer, as there were a lot of things that come up, and we did a separate cultural debriefing, and they asked for it. It was interesting that when they were talking about the medical management, everybody was speaking in English, because the medium of education in Pakistan for medical school is English. But when they are talking about counseling or dealing with the difficult conversation, they switched to Urdu language, which felt comfortable for the Indus EM resident, but it was a surprise to Yale PAM fellow because they do not understand, but this does not generate a discomfortness in them. And they said we ultimately understood that what might have happened, but as it was not a language they understood clearly, they cannot say what they have said at the moment. With this, I would like to go back again to you, and I found this very nice mindful reflection where you can share your roles, Thorn and Bird, and Rose is basically kind of your success. Thorn is a challenge, and Bird is a new idea or something you want to intend to work in that area. So I would like you to go back into the poll again, and this is a barcode. If in case you have like either closed the app already. So let's share with each other some of the roses, thorn and birds, and I will be finishing afterwards. And then I have some time after for the question and answer. So rose is highlight, success, small win, or something positive that happened recently in teaching and learning with culturally diverse setting. And if it is difficult to access, I'm okay to skip this portion and I just will tell mine. Okay, so why don't I skip it? And then I will tell my roses or strength of my study. Overall, the results showed that distance simulation training helped cultural understanding among learners during the debriefing session. Furthermore, the focus group allow us to have an open space of conversation where we are able to further have a discussion and reflection that allow us to have a better understanding of cultural sensitivity among the culturally diverse learner. Some of the thorns are inherent challenges of the distance simulation and focus group, that we are not able to get the non-verbal cues. It is a internet technology related challenge. And as we did this study with a specific population in Pakistan and US, generalizability of a result can take a further exploration. So the conclusion of this project is intercultural distance simulation experiences between culturally diverse learner can help promote cultural sensitivity. Our qualitative data analysis further identify the enablers and challenges of learner during the distance simulation in the intercultural context. And based on the experiences, although some obstacles need to be examined further, intercultural distance simulation was a helpful technique in promoting cultural sensitivity among the PAM learners from a diverse background. So how you can translate into other settings with some of our lesson learned, that starting with a get to know each other exercise before having a proper curriculum run is a good idea. Having a safety net for technical problems, considering religious aspect or other cultural belief, which is very much specific to that culture. Awareness of some of the linguistic, having a local co-facilitator with a native language or understanding of that language is always helpful. And facilitators should inform themselves about critical structural aspects that influence the teaching experiences and learners' engagement. And what is my goal moving forward is to develop a toolkit for a health profession educator regarding how to infuse cultural perspective in the curricula, which is underway, and to develop a workshop for simulation educators on how to develop and implement the culturally sensitive curricula with having validity evidence and reliability of clinical cultural competency questionnaire for simulation educator. These are some of the references, and these are my co-study authors. And please feel free, here is my email, and you can follow me on Twitter. Thank you so much. I'm happy to take any questions, comments, or clarification needed at this point.
Thanks so much, Jabeen. Maybe you could stop sharing your screen so we could see if people are raising their hands. And that was an excellent presentation, very informative, very innovative, and we're glad you were able to bring it to us today. Please feel free to put your questions in the chat. I can moderate the chat, and Jabeen will answer your questions if you'd like to speak up. I think we're seeing a lot of applause.
Thank you so
much. Add mine to the mix.
And I would say this is not an easy concept for me, myself, to understand. I struggle with it a lot. And I appreciate everybody's patience learning. I am not a qualitative or a researcher, so this is kind of a diving deep. And I always make fun of it, that I thought, oh my God, it will be so much fun and I will learn so much. And as much as I getting deep into it, I thought I know a lot, but I can tell you, it is just as much as I'm going deeper, it's more darkness that I have to explore rather than more light coming into it.
I think that speaks to the idea of productive struggle. When we're doing exciting work, that, you know, you're going to be in that zone of discomfort, right? I have a question to get things rolling, and maybe that'll warm people up to ask their questions. You mentioned towards the end, the facilitators felt unsafe. Whenever I see the term unsafe with SIM, because, you know, Jenny Rudolph has written a lot about psychological safety in SIM. I'm curious as to if you could expand a bit on what you meant by unsafe, because I think I know what you meant, but I'd like you, I wouldn't want to assume.
That is a very fair and a good question, and thanks for bringing it up. It was in the beginning, because what we did a meet and greet separately with the two group of learner, but we never brought them together. Like, they did not have a meet and greet session before the actual curriculum started. So what happened in the first 1 or 2 weeks, they felt like the PEM fellows and the EM resident felt a little bit unsafe, because they are all trainees at the end of the day. I know them very well, the EM resident, and I have a relationship, but I'm just bringing another new faces which are facilitating them. And we always have a fear. In Pakistan, there's a very high power distance. The PDI of Pakistan is at around 55, which is a very high, where facilitators are always right and learners are most of the time wrong, and they will not question their facilitator. So that's why the learners, EM learners, were very hesitant to speak up, because they thought they are practicing PEM in Pakistan where there's no PEM training, so they might be saying things which are wrong. And the PEM Yale fellow was a little bit hesitant in facilitating, because they thought that they are learners themselves, how they can teach learners from a different university by saying you should do this or you should not do this, something like that. So, but after 2 or 3 sessions, they become very much like, they start chatting with each other. We make a WhatsApp group. There's a lot of interaction that happened afterwards. So it was in the first or 2 sessions, and we learned a lesson that, especially if we are incorporating very distinct population of learner to interact with each other, or even for us, we need to know the setting and we need to know each other before we will jump into teaching or learning with them.
Thank you. That makes sense. A few people have had to hop off and we have 3 minutes left. Any other questions, comments for Jabeen?
Yes, Catherine has a comment. Yeah, Catherine, it also what they said, because it is very interesting that we ask them all the question about culture and they keep on diverting on the medical part of the curriculum rather than focusing on the culture part. So it also indicate our kind of blind spot when what we want to talk about. So what they said that the scenarios reflected very well to the patient population that they are seeing, and they learned a lot how to interact or how to deal with the difficult situation, and their whole concept of because they are all adult EM residents, so their focus is most of the time is the patient, and how now they are also including parents as a part of that care team, which they were not considering initially. So this is a kind of a change that happened among them as a result of the culturally adaptive scenarios.
Okay, so it's 12:59 and oh, there's another question just came in. How do you use these cultural differences to support rather than divide discussion in SIM and in general their practice?
Yeah, so that is a very interesting question. That was not kind of at all the intention. The intention was that having a curriculum for EM resident to be more, that is more near to their culture or more near to their clinical context. So I did not, I literally in the debriefing, because the PEM fellows were leading it. So if they brought, then the co-facilitator elaborated. And if they do not talk about it at all, then the co-facilitator ask or probe them by advocacy and inquiry and bring them to the cultural perspective. So I would say that it was more kind of a mutual learning rather than we intentionally dividing them. And then in the focus group, we do ask them, probe them that how it is different from your culture versus the US culture versus Pakistani culture. So I would say during the session, this does not happen much, but yes, in focus group, we were able to probe it a little bit further.
Thank you so much again. Have a wonderful week, everyone. And join us next month, early in the month, May 4th, for Dr. Ryan Bridges, who will be presenting at our next SimCity rounds.
Thank you so much for inviting me. It's such a pleasure to be with you all.
Take care.
Thank you. Take care.